Hello friends, this is Dr Sourabh Patwardhan from Nandadeep Eye Hospital, PG Institute Training Center from Sangli, India. In this video, I'll be speaking about a case of mature cataract with adherent leukoma and the leap of faith that we have to take in such cases. So this is a patient, 55-year-old male, intumescent mature cataract, adherent leukoma with opacity, and patient is one-eyed. So I'm going to operate the patient under subconjunctival anesthesia. So I am giving some subconjunctival anesthesia in the infranasal quadrant, followed by posterior subtenon anesthesia using 1.5 cc xylocaine. This is a very good method of anesthesia, gives good analgesia, though the eye movements are there. The procedure here is a bit tough because of the reduced visibility due to corneal opacity and adherent leukoma. Patient has intumescent cataract, so I have stained the anterior capsule well with trypan blue, and I am going to use the combination of chondroitin and hyaluronate, heavy dispersive OVD to protect the endothelium during the procedure and also helping me in the capsulorhexis. So I just checked with the Sinski whether the adhesion is strong, but it was not that strong, so I could release it just using Sinski. Otherwise I will use curved scissor. Now this is the area of opacity. This is the area where I am not going to visualize the anterior capsule. That is the blind area for the surgeon. So I start off with the initial cruciate incision, which is my favorite method for managing the intumescent cataract, followed by aspiration of the liquefied cortex from the bag. And once the aspiration is done, I just stroke the peripheral capsule so that there are no fluid pockets, and then I proceed with the capsulorhexis. So I lift the flap, and in the visible area I want the capsulorhexis to be of good size. I don't want a small capsulorhexis in this case. Now I shift to microcapsulorhexis forceps and continue with the capsulorhexis. And once I reach this area where the visibility is not there, it reminds me of this famous movie scene from Mission Impossible. So this is the leap of faith that we have to take. So we have to judge how the flap is proceeding, and luckily, as we see here, the leap of faith has worked. I could grab the flap well and complete the capsulorhexis. Though it is a leap of faith, definitely experience and understanding of the flap movement and control over the instruments help us getting through these difficult parts of the procedure. Once the capsulorhexis is complete, the surgeon is much relieved because now we can go ahead with phacoemulsification. When we start, we have to focus on the zone of visibility. So we have to do all the maneuvers in that zone. Here I am going to do trench divide, making good deep trench and dividing the nucleus. It's an intumescent cataract, not very hard, but we have to carefully divide it into 4 pieces. No need to hurry in any steps. Make sure that the deep trench is made before we divide it into small pieces, and then start emulsifying in the visible area. There is a heavy dispersive OVD containing chondroitin and hyaluronate, which is guarding the endothelium here, and I am trying to do maximum phacoemulsification when the nucleus is occluding the tip and at the iris plane, thus reducing the phaco energy which is dissipated in the anterior chamber. I always use lower parameters than usual for such cases because of poor visibility. We cannot actually visualize the movements of the posterior capsule in such cases. So it is best if we reduce our vacuum parameters by around 25 to 30% in such cases and go slow. For cortex aspiration, use very low vacuum. One can also use iris hooks in this case, but as you can see here, the main area of working, a part of it is opaque. So even if I use the iris hooks, the central zone will be still area of poor visibility. Luckily, we have got a good temporal corneal zone which is clearer. So we did most of the important maneuvers of trench division and emulsification of the quadrants in that area. While injecting IL also, we have to make sure that both the haptics go in the bag and once you are sure, you can remove the OVD, and that's the end of the procedure. Patient did really well after the surgery. For more such videos and for phaco training, do subscribe to my YouTube channel, and you can also visit our website phacotraining.org.in. Thank you so much.